the kidney.
El kidney. I think that's how you say it.
El
in Spanish.
riñón.
Oh, all right, fine.
Or El kidney. It really depends. I think it's regional.
It's colloquial.
it's
I don't want to challenge you on it, like in
dialects.
front of all these people, but I'm pretty sure it's El kidney. But that's fine. We can look it up later. Agree to disagree.
We'll agree to disagree. I like it. So abdominal pain, flank pain, hematuria, just like AAA.
Yeah.
So if it's a retroperitoneal thing you're worried about, or these things make you think of the retroperitoneum, you should probably look at both, depending on the patient. If it's a 25-year-old with known kidney stones, maybe not look at the aorta. And if it's an 80-year-old and you feel so good about your ultrasound that the aorta is normal, that you want to go look at kidney stones,
Makes sense.
go for
Standard.
Yep.
it. Okay.
Oh, hey, it's our friends.
Our friends.
The probe.
Yeah.
I always feel like if one of those, this is probably totally clinically, or you can tell me, you know how you said you can pick one because that one fits better between the ribs, but some people have no problem. The people that have no problem with that big probe are people who go like, "Roar!" and like just separate the ribs on their own.
You
So,
could do that.
yeah.
You could do that. I would say that, if we're going to be on topic and based on our blazing pace, I think we'll be probably
good.
faster. We can
solid.
slow down a little bit.
Yeah.
This one lets you put more force on the patient without hurting them.
That's what I
Not
would
through the
imagine.
ribs, because
Yeah.
that's going to hurt. But if you're looking at the abdominal aorta,
Yeah.
the big technical challenge is going to be bowel gas in most of these patients. And you really need to push down and displace the bowel gas. If you have that curved probe, you can apply a lot of pressure. And in an obese person, putting both hands on it and leaning on it isn't uncommon. And you'll be able to move the bowel gas out of the way. It's a nice, smooth, curved surface. If you take that phased array, the echo probe essentially, with the little sharp edges on it, and try and do the same thing. It's a lot more like stabbing them.
Yeah,
Yeah,
it's like
yeah.
a
Opposed to
stiletto
massaging
heels
them.
versus like a
You might
sneakers.
need that probe for you since you had a lot of Korean barbecue last night.
Oh yeah,
We're gonna have to separate some bowel. I
You
must sit on
can't
that
see
probe.
my
I'm gonna be
aorta.
like,
Yeah, there is no technology
put my knee into
available.
that thing, and I'll be like, all right.
All right. This looks a lot like our fast exam.
Yeah.
And the reason I put this same image in is because I do these exactly the same.
Good.
Got it.
So
Use the
anterior
liver.
axillary line, use the liver as a window, point down to the kidney.
Okay.
Same thing on the left side.
Love it.
And that's what we're looking for.
Hello,
we're looking
kidney.
for a kidney. So you'll get vertebral
vessel in
column
there.
often down here. You'll see some of you may see this structure over here, which is going to be your iliopsoas. And then liver and kidney. And those are the only things really in the area.
Awesome.
You'll get these little triangular hypoechoic
Yeah.
foci structures out in the cortex. Those are just pyramids.
Yep.
So that's normal. And then in the hilum of the kidney or the pelvis, you'll see mostly echogenic appearance. So this is a normal kidney.
In a normal kidney, yeah.
Oh, hello.
And then here's a moderate hydronephrosis. And you'll see splaying of the calyces. So they get split apart. The renal pelvis gets full. Proximal ureter's full here. And you've got this anechoic collection inside the renal pelvis. This is a pretty straightforward application.
If
Where
you were to
peop-
get on the test, this would be the classic.
it's going to be that, or it's going to be something like this.
That's
yeah.
right.
Right. So this is the bear claw appearance of
Makes me hungry.
severe hydro. I know bear claws make me
That's
hungry.
weird, man.
The bear claw pastries.
Yeah, I know. Everything makes you hungry for bear claw pastries.
There were probably a couple of bear claws in that box of donuts that he allegedly brought
The
today.
box of donuts that
Yeah.
you said you were going to bring, but actually you ate in your car.
Yeah. All right. And then, this is more of an aside for clinical practice, I think, than for the boards. But if you start looking at renal colic or suspected renal colic patients and start doing it with ultrasound really regularly, you are going to get good enough that you're going to start finding not only hydronephrosis, but finding stones.
Mm-hmm.
And this is gigantic,
Oh, wow.
right? This
Yeah,
is a
yeah.
centimeter stone that's at the UVJ
Oh,
on the
interesting.
right, so right at the ureterovesicular junction. But I would say that of the people I know who do this regularly and not only look for stones, hydro, but also look for stones, 40 to 50% of the time,
You can
if
find
it's
it.
renal
Oh, wow.
colic, you find not only the hydro, but the stone.
So it shadows out just like it's supposed to. And
It
all that?
typically shadows out if it's large.
Okay.
Sometimes it won't shadow quite as clearly.
So just to set the context, this is the suprapubic or pelvic
So this
view,
is a
the
transverse view of the pelvis.
Got it, okay.
You've
That's
got
a bladder
prostate
then.
down here
Mm-hmm.
and bladder, and then stone and shadow.
Got it.
And you'll see these both proximally up at the ureteropelvic junction. You'll see it distally at the UVJ like this. And then if you're a real ultrasound nerd, you may track the ureter and try and find it somewhere along its course. But most stones lodge at the UVJ.
Yeah.
Makes sense.
Some of them proximally. And being able to call your urologist and say, I've got a 35-year-old guy with really severe symptoms who's got a 1.2 centimeter stone at the UVJ with some hydro
Right.
is a lot different from I've got a guy who I'm suspecting renal colic because there's hydronephrosis,
Right.
which is
Yeah.
going to inevitably get you the answer of do
What's
a
the
CT.
CT scan?
Yeah.
Yeah, exactly.
Right. So this is a nice thing if you're able to see it.
Cool.
It's worth looking. It doesn't take that much practice.
Cool.
So
It's
it's
a
a
nice
pitfall. Right. You can have focal hydronephrosis in patients when you get a stone lodged like right there, and you'll see one calyx that's just dilated. But this is a pretty classic cyst, simple cyst. It's bordering on being not simple because it's over 3 centimeters, but it's anechoic. It's got smooth walls. There's no bumps or
circumcised. It's
You know,
clearly
I-
circumcised. I don't want to
I
get
didn't
into
do
why
a
I know that.
full exam on this patient.
Yeah, I did. No, I just. I'm gonna hold back all 3 jokes that I want to make right now. I'm gonna hold back.
Circumscribed.
And we're gonna
Yeah.
say circumscribed. That's
Yeah,
what it is.
sure. That's what it is.
Let's just move on.
Right
I
in
didn't say it.
slip.
So I do get this question clinically from people who are learning ultrasound about when do you refer a patient for a renal cyst, and most people agree over 3 centimeters, and it's an outpatient referral for a outpatient ultrasound, maybe an outpatient MRI, and some following it over time. But if you see a cyst that has some tissue along the wall or calcification in the wall, or it's irregularly shaped, those are obviously much more concerning for malignancy. For our purposes, we're really just looking for hydro or no hydro. You may get a question like this on the boards. This wouldn't shock me if they said you do an ultrasound and suspect renal colic, and they show you this, and they want you to know that it's not hydronephrosis.
Got it. Okay.
Circumcision may or may not be in the stem.
It's usually outpatient ultrasound, circumcision, MRI. That's the
75-year-old
progression.
man circumcised. I understand where it's gonna come from. I'm with it now. I'm gonna pass it.
Whoa, what the heck are we looking at?
Yeah.
We're looking all polycystic on me.
Yeah, so that's polycystic, absolutely. So typically, people talk about hyperkalemia makes you say, "Whoa, what am I looking at?" When you look at an EKG, polycystic
Right.
kidney disease is going to do the same. There's no architecture that's recognizable.
Right.
There's a lot of cystic structures, and where's the kidney?
As opposed to the bear claw, right? Which you could also honestly, I mean, the bear claw looks more organized than this.
Definitely.
You know, so
Yep.
you're going, okay, that's a massive hydro. This is more polycystic looking.
Yep, totally agree.
Pattern recognition.
And just while we're on the topic of ultrasound pearls and stuff, what's this?
That is.
If
The
it
IVC?
plays, it may give you a little more perspective, but we'll let
I
it
can't tell
start
if
from
it's
the
going
beginning.
into the right atrium or not.
Yeah, so this is left kidney, and you know that because
Oh.
the spleen is tiny.
Oh,
Right, right.
okay.
And that's your abdominal aorta.
Ah.
So in the few cases where you end up with the pre-hospital collapse and resuscitation patient with a ruptured AAA,
Oh.
you often won't see anything abdominally because all the pressure in the world's not going to get rid of the liter of air that they've pumped in doing bag valve mask
yeah,
ventilation.
yeah.
And the flank is a great, you can look at it from both sides. It's easier from the left a lot of the time, but you'll get a good longitudinal look at the aorta from here. And you could say, okay,
That's
well, that's
cool. Yeah.
less than 2 centimeters.
Wow.
So they don't also have a AAA on top of their polycystic kidney disease.